Please, Agi Emmanuel Tender, mute your mic.
Oh.
Good evening, everyone, and welcome. We are having our last lecture for the course today, after which you will do your continuous assessment and exam. So please,
Good evening, Prof.
good evening, everyone. So let me, please just, you can all mute yourselves so that we can just run through these lectures quickly. Yeah, thank you very much.
Prof, good evening, welcome, sir.
Please, we have always said that when you come for a lecture like this, identify yourself. Somebody having number 415439, please, we don't allow it. No, we don't want strangers in our midst. If you are part of us, please be free to put your name, put your full name there. Let's know you are in class, please. Whoever is 415439, please, I beg of you, just rename your device. Let's have your name. You can see my name there. I'm not hiding my name. I'm not stealing. So please put your name. Let's know you are the one, please. Otherwise, we'll block your number. Block you. We'll make sure you are not part of it. Please put your name. Okay, we're 10 minutes gone into our lecture, so I think we can start. Others can join us as they come. Let me make some.
Combined service that we via Canary Wharf. The next station is Tappington.
Are the course reps online? I want to make someone a co-host in case. Who is comfortable with using Zoom? Okay. So that I make you a co-host, or I can see you. All right, fine. Please raise your hand to make it easier for me to identify you. Just raise your hand so that it will come up and identify you because of the number. All right. No, I didn't ask everybody. I just want to make a few persons co-host so that in case if anything happens, it could transfer. If my distance is not stable. If you know that you can retransfer it to us, fine, no problem. That's just all I want. So I have to. Okay, so that's all. Thank you. You can bring down your hand. That's all. You can bring down your hand. So let's go. Others, as they come, they will join us. Okay, I think we have formed org now. So today we are just going to look at preventive strategies for non-communicable diseases. There are many, so I want to be fast. I believe you have read them. I've given them before, earlier than now to you. As I mentioned in passing yesterday, non-communicable diseases are chronic diseases that are not communicable. They are not transferable from one person to another. And for that reason, because they are not transferable from one person to another, many times we would have expected that their prevalence will be lower compared to communicable diseases that is easily transferable from one person to another. But alas, that is not the case. You know, over the years, we had more of communicable diseases. But as time is going, because of lifestyle factors, we are now having a lot of non-communicable diseases. Not only lifestyle factors, our healthcare system is also developing. Before now, when our healthcare system was very weak, even if we had sufficient number of those non-communicable diseases, we were unable to detect them. And when we are unable to detect them, we assume they were not there. But now the healthcare system is slightly stronger than it used to be. We are slightly wiser, better equipped, more educated. So we are now finding them out easily. So it can now be arguable. It is possible that it's not increasing. It has always been like that, but because of the weak healthcare system, we are unable to detect them and we assume they were not there. Or the other way, we can't say for sure. But all we know now is that it's rising. And because it is rising and rapidly too, because of lifestyle factors. So we now say that in developing countries, we are now having a double burden of disease. If in developed countries, they have high burden of non-communicable diseases, that's true. Before, developing countries, high burden of communicable diseases. That is a transition. But now, a transition is taking place. While we are having a gradual decline in communicable diseases because of immunization, use of antibiotics, slightly better healthcare system. So we are having some sort of decline in the non-communicable communicable diseases. At the same time, we are having an upsurge, an increasing number of communicable diseases. So where we are at present is that we now have a double burden on both sides. We have not succeeded completely in reducing communicable diseases, and the non-communicable diseases are fast emerging. So we are caught in between the web. So that is why. So diseases like, when we are talking about non-communicable diseases, we are talking about diseases like heart diseases, respiratory diseases, cancers, diabetes mellitus, and the rest of them. There are a lot of them, arthritis, and so many of these diseases. They are not transferable from one person to another, but there are some genetic predisposition, some familial predisposition in some of them, obesity and the rest. However, we know from medical science, from preventive medicine, that even where family predisposition exists, environmental influence can affect the individuals positively. That is, people who have high risk because of family predisposition can modify that risk through environmental factors. I'll explain what I mean. So we attribute the rising incidence or prevalence rate of non-communicable disease to social changes in our society, okay, such as people now, a lot of people moving from rural areas to urban areas, looking for greener pastures, right? Structural changes, that is, we have increasing urbanization, and increasing urbanization comes with its own unhealthy lifestyles. You see, a lot of people are living in squatter population. A lot of people are highly stressed up because of when people are gathered in the cities, job becomes scarce and things like that. Housing becomes scarce. So a lot of stressors, and people begin to prematurely develop, hypertension and the rest of them because of the various burdens that they are going through. Okay, their financial security is limited. Their ability to work is also limited. They cannot afford healthcare and all that. So when we look at the Nigerian situation, we see that the non-communicable diseases in Nigeria have also been increasing at a fast rate, right? It was recorded about slightly over 500 per thousand population in males and 546 in females in 2021. All right. So with total death from non-communicable disease was about slightly above 2 million as at 2014. And the commonest causes in Nigeria from cardiovascular diseases. Cardiovascular diseases, cancers, they form 7%. Cancers, chronic respiratory diseases, diabetes, then the rest, the other non-communicable diseases, including injuries, road traffic accident. That one is a very major one. So the probability of dying between the ages of 30 and 70 from 4 non-communicable diseases at that time was about 20%, which is high. So non-communicable diseases exhibit certain characteristics. They exhibit certain characteristics. The first one is complex etiology. We've talked about it in the past. Complex etiology because the actual causes are not known. The actual causes are not known. It's complex in a way. It could be caused from diverse angles, diverse sources. Unlike communicable diseases, measles is measles virus, tetanus is tetanus bacteria. So we can pinpoint the cause, but hypertension, we cannot easily. Hypertension can come from the angle of stress factors, which we call essential hypertension. It can be secondary hypertension, maybe from kidney, from endocrine system and all that. So it can come from diverse sources. It can come from, too many sources. So that's why the etiology can be complex. The same thing, the risk factors can also be very complex, multiple. They go with multiple risk factors at the same time, not one risk factor. Then it has a long latency period. Latency period, as you all know by now, is equivalent of incubation period. That is the time of exposure to the time of manifestation of the disease. That is the latency period. Many times, because non-communicable disease, they are so insidious, they come unnoticed. You know, the insidious, they unnoticed. People begin to suffer from them. A lot of people suffer from non-communicable disease without an idea that they are suffering from one disease or the other. So because of that, the latency period is unnoticed. That is why it is adopted that whenever the definitive diagnosis is made, that is when we say the disease began. Of course, it's non-contagious, just as we said earlier, it's non-contagious. So these are the characteristics, and it has a prolonged course of action, illness. For instance, when somebody is suffering from diabetes, it's forever. We never say we have a complete cure. Whenever you see any doctor or, say, oh, I can cure hypertension completely or diabetes completely, know that that person is practicing alternative medicine. It's not orthodox medicine, because there are several medicines, as you all know. All the street corner, everybody is a healer. There's spiritual healing, there's voodoo, all types of healing. So, but when you see that, when you hear that I will cure you of hypertension once and for all, which everybody will like, of course, is desirable. When you hear that, fine, just know that it's alternative, because medical science, even though medical science wants that result, it has not been able to achieve that. Then it can lead to functional impairment over time, right? So the risk factors, so when it comes to, say, an aspect of personal behavior or lifestyle and environmental exposure or hereditary characteristics that is associated with an increase in the occurrence of a particular disease. So that is what a risk factor is, right? An aspect of that behavior or lifestyle, particularly in terms of non-communicable diseases. Okay, so the risk factors for non-communicable diseases that influence individuals, households, and communities are driven by social and economic determinants. There are determinants we call social determinants of health. Those are things that determine, their risk factors. Social determinants of health are social factors that actually determine health outcome. Social factors that can determine health outcome. For instance, crowded living can determine health outcome. It can lead to transference of infection, for instance, because of crowding. It can lead to injuries because of the crowding. Okay, so there are social factors. Poverty can have impact on health. Inability to access health care, financial access lacking. So there are social determinants of health. These are social determinants of health. For instance, also, say, when there is absence of potable water and people are forced to drink any available water, we could have episodes of diarrhea and all that. So these are social determinants. There are determinants, so the main risk factors for non-communicable disease as identified are tobacco use in any form. Tobacco use comes in diverse forms. Some chew it, some smoke it, inhale it, shisha. They come in different, forms, okay? Then physical inactivity, adynamia, not making sufficient movement, sitting in the car all the time in the name of enjoyment. No. Harmful use of alcohol. You see, look at the way alcohol is classified here. Harmful use of alcohol. So that we're not saying that any use of alcohol is completely no. That is not this message. This message is saying harmful use of alcohol or harmful alcohol use. That is when somebody uses doses that are abnormal for that individual, that can hurt the person's health. Unhealthy diets that are full of trans fat and all that, okay? Trans fat forms covalent bonds, and those covalent bonds, are not things that can be easily metabolized or broken down. So the risk factors can be acting singly or in combination. These risk factors could act singly or in combination. For instance, some people who are smokers at the same time use alcohol to very dangerous levels, okay? Or any other combination. It can happen that way, okay? So these factors contribute to non-communicable diseases, okay? They contribute to non-communicable diseases. Other factors that contribute to non-communicable diseases include things like poverty, globalization, trade, education, and all that, urbanization, climate change, so many factors, all these depend on how you can rationalize them, so there are a lot of them. When people, otherwise you can say, how will education, for instance, education would have been a very good asset to healthcare, but it can work the other way. When people get educated, people get high level of what do you call it, income and all that, maybe the usual food they eat is now seen as very local and unworthy of their status. So they go for, what they think is good, not knowing that that is the real bad food. All right. So, however, in all this, the WHO actually prioritizes these four: physical inactivity, tobacco use is in any form, alcohol use, harmful alcohol use, and unhealthy diets. And these include fat or trans fat, high sodium content in foods, low fruit and vegetable intake, low content of fruits and vegetables. So those ones are also. Now, these factors are called modifiable factors. These factors, the physical inactivity, it can be modified. People can decide to increase their physical activity, so it can be modified. Tobacco use, people can decide to stop smoking. It can be modified. Okay. Others too. Other factors. Okay. Other factors. Like alcohol. Somebody can decide to take alcohol sparingly and it becomes harmless, and others. So these ones, somebody can decide to increase consumption of fruits and vegetables, and that can, modify the diet. Okay, but there are no modifiable ones. Like age, nothing can be done about them. Non-modifiable factors are those factors that cannot be reduced or controlled by any intervention. But this inference is being challenged, seriously challenged by environmental factors. What do I mean? We know that one's age can never change. The chronological age can never change. It's known. No matter how you look young, your age remains your age. We know the same thing, that gender cannot change, irrespective of attempts globally. Now, transgender, this somebody will just say, okay, I'm tired of being a male. I now want to become a woman, and things like that. Or race, you know, you can't change your race. No matter how you change your skin color, these ones that are non-modifiable, or genetics, one's genetics, because those are inherent characteristics, you know, from creation. Those cannot be changed. But in terms of disease, non-communicable disease, it's been found, a lot of studies have said that, okay, we know that non-communicable diseases increases with aging, because like things like atherosclerosis, deposits in the blood vessels begin to, you know, clog the blood vessels with age and all that. But it's also been known that with a lot of physical activity, physical exercises, those processes are hindered from taking place. And when those processes are hindered from taking place, even if the person is old, you find that the predisposition to those non-communicable diseases become reduced. That is why this one is being challenged, you know. So that is what that is. So there are modifiable factors. There are also non-modifiable factors. Okay. There are modifiable factors and non-modifiable factors. And in fact, now there are other factors which, you know, that are being promoted, like the metabolic risk factors. So you have the modifiable factors, non-modifiable risk factors, metabolic risk factors. Okay, the metabolic risk factors are the biochemical processes, you know, involved in the body's normal functioning. And these ones are usually related to physiological or metabolic changes in the body, like raised blood pressure, total cholesterol, glucose, and weight and overweight and obesity. Okay, these are, but strictly speaking, some of these ordinarily can be found in modifiable in factors, but WHO has brought them out, you know, separate, has called them metabolic factors because of the physiological processes involved in their formation. So going to specifics now, the first disease here among the non-communicable is hypertension. It's simply raised blood pressure level. So it's a condition which the blood vessels contracts, relaxes. That movement generates pressure that propels blood to circulate blood around the body. And as blood is circulated around the body, goes up to the lungs, one breathes, oxygen exchange takes place in the lung, it transports the oxygen, you know, through the circulatory system to all vital organs and tissues and cells for perfusion. You know, that's what your hemoglobin does through the blood. So it requires that pressure in order to circulate the blood around. So as it contracts, a particular pressure is created. That is called the systolic pressure. And as it relaxes, the pressure relaxes. That is called the diastolic pressure. That is why many times when you measure your blood pressure, you say, which one is the upper value, which one is the lower value? The upper value is the systolic pressure. That's the pressure on the heart when it contracts, and the diastolic pressure, the pressure in the heart when it relaxes. Okay? So the heart, the blood vessels operate with a known amount of pressure, sufficient enough to circulate blood. When this pressure becomes high, it becomes a serious medical condition, okay? And becomes a very high risk to the heart itself, the coronary blood vessels. The heart vessels are called coronary blood vessels, to the brain, to the kidneys, and other parts of the body. Now, it's a major cause of premature death, high blood pressure. It's upwards of 1 in 4 men and 1 in 5. In 1 in 4 in men, 1 in 5 in women. Over 1 billion people are having the condition globally, high blood pressure, but it is highest among the people of African origin. High blood pressure is highest among the people of African origin for whatever reasons. So that even people of African descent in diaspora, even, in the Caribbeans, in the Americas, the African Americans have higher proportional level of blood pressure compared to the Caucasians. Now, the burden of high blood pressure is also disproportionately higher in low and medium income countries. Low and medium income countries, where 2/3 of diseases are found, largely due to increased risk factors in those populations in recent decades. Now, high blood pressure is particularly called an iceberg disease. So you can see the picture of typical iceberg. I was trying to illustrate it in the earlier part of the lesson. You see, this is how an iceberg floats in the lesson. When you see the tip, when you look at the tip, it seems as if, it's a small body. Submerged ones is huge. So you can see how it is like this. So what it's trying to say here is that a lot of people who have hypertension are in this category. Submerged, they are unnoticed, okay? Are unnoticed, they are not visible. The visible ones, people, the healthcare system can take note, are just a small fraction. So it's an iceberg disease. That is why some people call it the silent killer, because it kills people when the people did not even know. All right, so this is just, blood pressure is measured with a sphygmomanometer equipment called sphygmomanometer. And these are the normal levels presented here. Normal level, pre-hypertension, and hypertension, okay, for both diastolic and systolic. At times, some people will ask the question, which is the most important? Systolic, which is most dangerous, high systolic or high diastolic? Interesting question, but the truth of the matter is both of them are dangerous. Both of them are dangerous, okay? But some would prefer that the systolic pressure, because it could, if it's so much, it could burst the blood vessels, where the blood vessels are thin, the epithelial cells are thin, like in the brain, and could cause hemorrhagic stroke. Okay, it could cause hemorrhagic stroke. Right, okay? Now, risk factors are hypertension, ethnicity, people of African descent, the non-modifiable risk factors, age after 35 years, and family history of hypertension. Then modifiable ones, being overweight and or obese, these ones, history of smoking, high dietary intake of salt. The recommended, WHO recommended standard is about 5 grams per day, but some people like a lot of salt. You know, salt is sweet. That's when you go to fast food, most of the food are highly salted. In fact, to even conceal those ones that are not tasty, they just put so much salt that you won't know that you are just eating trash. Excessive use of alcohol, sedentary lifestyle, high level of stress, and poorly controlled diabetes. Okay, when diabetes are poorly controlled, it affects the blood vessels. It affects the blood vessels, and we can increase blood pressure. So what are the common signs and symptoms? For most parts, there are no signs and symptoms. That is why it's called a silent killer. Most people with hypertension are unaware of the problem because, some will say, if somebody ever told me that, and when I told the person to check his blood pressure, he said, no, it's not blood pressure. I know when my blood pressure, I will feel somehow. And that is a terribly, very dangerous. I just looked at him. I told him that you are taking a very dangerous risk, because unfortunate thing that you might not be here for me to tell you, but I told you, then you are gone. If I would just be talking to air, so for this reason, it's essential for people to check their blood pressure regularly. Then when symptoms do occur, they used to include like early morning headache, especially in the occipital region, at the occiput, at the back. Early morning, it could come with nosebleeds, irregular, palpitation, or irregular rhythm of the heart. At times, it can come with vision changes, which people can think that, maybe because of aging, vision is presbyopia. That is why when you go to the eye clinic, the first thing is to check your blood pressure. Or it can come from noise buzzing in the ears, okay? But severe hypertension can cause fatigue, nausea, vomiting, confusion, anxiety, chest pain, muscle tremors, and all that. If blood pressure is quickly measured, then the risk can be controlled. To detect blood pressure is very simple with your sphygmomanometer. Now we have the automated ones. They're everywhere. You can pick them up. It's a good practice to have one in a home, because there are things people can do for themselves, and learn the appropriate way to measure it, because even though people can pick them at almost not too much cost, but there are methods on how the blood pressure is properly measured. It's not just putting in the hand. No. There are step-by-step approach to measure it normally. Otherwise, the result might not be very correct. So what are the complications of uncontrolled hypertension? Among the complications are hardening of the blood vessels, arteries. And when the arteries harden, okay, when the arteries harden, what happens? They become brittle, when they become brittle, they can break. Under normal condition, the arteries are liable or pliable. That is, can expand and come back, soft and liable. But with time, when the pressure in them become persistently high over time, they harden. And when they harden, a sudden upsurge in pressure, they can break. Okay, unlike when, it was expanding and contracting, so it can be like that. So, and when that happens, there could be decreased flow to vital organs in the body, particularly the brain and the heart. In the brain, it can now cause ischemic stroke. When blood supply cannot reach the brain cells will begin to die. The people can now develop stroke, the ischemic stroke. We have two particular types, the hemorrhagic and the ischemic, but that's not our subject. That's more of clinical medicine. So let's go on. Then elevated blood pressure also can cause chest pain, angina pectoris, okay, and all that. Heart attack, that's what heart attack would have all heard about what is called heart attack. And when the blood vessels in the heart itself, the coronary blood vessels, are blocked, those areas are no longer supplied with oxygen. The cells die and get rotten and can get busted. That is myocardial infarction or heart attack. So the longer blood flow is blocked, the greater damage to the heart. Okay. So heart failure, which occurs when the heart cannot pump enough blood and oxygen to vital organs. There are many causes. Maybe if heart is so enlarged, it can lead to heart failure. And the heart is unable to contract fully well when the blood pressure in them are so high and it cannot contract. And you know the heart works by a principle of all or none, and it begins to fail if it's unable to do so. Irregular heartbeat can also lead to sudden death. Irregular heartbeat can lead to sudden death because when there is dysrhythmias and or arrhythmias, when it's very high, that high rate of contraction of this heart, there is no depth in the contraction. So despite the heart is now contracting at a rate of 150 beats per minute, it's not succeeding in pushing blood, circulating blood around the body. So sudden death can occur. Okay, well, we talked about it can burst in the brain to cause stroke. Hypertension can cause kidney damage, leading to kidney failure. Majority of the cases of kidney failure we see around, people are peeling for 50 million, this, that. Majority of them, I can say with all certainty, is as a result of hypertension. Hypertension and kidney works like in a vicious circle. When the blood pressure is high, it damages the kidney cells, the glomerulus and all that. When it damages the kidney cells, now the kidney cells, because they are damaged, some chemical reactions take place that leads to increased blood pressure. So the higher the blood pressure becomes, the higher damage it causes to the kidney, the more damage it causes to the kidney leads to higher blood pressure. So it becomes a vicious circle. Those of you who studied physiology, maybe you will know what I'm talking about. Or those of you who are physicians, you will know when you look at the annual, then the preventive strategies. Let us look at the preventive strategies. Look at the risk factors: obesity, inadequate physical activity, stress, tobacco use, and all that. Okay, so when you look at the primordial prevention, you create awareness program, let people understand what hypertension is. It is deadly. Then screening for hypertension, okay, especially high-risk groups, high-risk screening, I'm sure you did screening, okay? Then primary prevention, lifestyle modification, okay? Changing of diet and all that, weight reduction, increase in physical activity, cessation of smoking, reduction of, those are primary prevention. Then secondary prevention, strategic control of hypertension, okay? Screening for complications, carrying out kidney function tests, particularly looking for, look out for sodium, potassium, creatinine, creatinine clearance, just kidney function test and all that. Okay, just put it like a kidney function test. All right, then tertiary prevention of treatment of complications, management of primary care level complications, any type of complications that can arise from blood pressure. Complications like stroke, others can be handled at the tertiary level. So reduce salt intakes, less than 5 grams per day, eating more fruits and vegetables, physical activity on a regular basis. The physical activity recommended requires just about 30 minutes of physical activity 5 times a day, about 150 minutes a week. And 30 minutes ensure that the evidence to show that the physical activity is sufficient enough is when there's some signs of some sweating. That shows that blood has circulated, okay? Then reduction of alcohol intake, we talked about this, and reducing trans fat in the diet. Then the next one is diabetes mellitus. It is a heterogeneous group of diseases also characterized by a state of chronic elevation of glucose level. Glucose level in the blood is not supposed to be elevated beyond a certain level. because the insulin apparatus is the mediator regulating the flow, the level. So a result, it can come from several etiologies, can be environmental, genetic, sometimes, both of them acting together. Okay, the underlying cause of diabetes is relative or absolute deficiency in insulin production or action. That is why we're talking about insulin resistance. So when we say diabetes, it is simply either relative or absolute deficiency in insulin production or action. That is diabetes. Insulin apparatus produced by the pancreas converts the glucose we eat into glycogen stored as fat. That's basic biology, right? So now, if it's insufficient, most times we can make it sufficient by administering drugs. And those drugs, the oral glycemic drugs, okay? You know them alone, the Micron, the Abinase, there are so many of them, okay? Those ones, the aim is to push the insulin apparatus to release more insulin into the bloodstream. But where there is absolute deficiency, that is as insulin apparatus is not producing at all, absolute, which originally we call type 1 diabetes. The other one that's relative deficiency is the type 2 diabetes. Okay, the type 1 diabetes is absolute deficiency. In that case, people use injectables, insulin. You have to just introduce insulin externally in the body. Okay, then another thing that can cause problem is insulin resistance, whereby the insulin is there, but the cells are unable to absorb them, work with them. So insulin is a hormone that controls glucose, fat, and amino acid metabolism. So characteristically, diabetes is a long-term disease with variable clinical manifestation, progression, and outcome. So chronic hyperglycemia from whatever cause, leads to several complications that can affect the heart, the kidney, the nervous system, the eyes, the reproductive organ, and all that, even increase in infectious disease, the potential for infectious diseases. When somebody begins to frequently experience infectious disease, somebody gets infected at the slightest, this in every infectious disease, is good to test for diabetes. Okay. Because that proneness is one of those, or when somebody, the eyes, or a male having some, erectile issues, is also good to test for blood glucose. Okay, classify, they can have type 1, insulin-dependent diabetes, or type 2 non-insulin dependent diabetes. Okay, then we have the impaired glucose tolerance, which is called the pre-diabetes or the gestational diabetes that occurs, in pregnancy. But I don't know whether for time's sake I will mention about these. Are just data you can read on your own, or you would have read on your own. So type 1 diabetes here we're talking about is the most severe form. It occurs more in early adolescent and among young people, typically not beyond the age of 30 years, much younger people. Type 1 diabetes is the most severe form of diabetes. This one, the people need to have to inject insulin all through life. It is all very lethal, unless if it is diagnosed and treated properly. Okay, this form of diabetes is immune mediated in over 80% of cases, and idiopathic. They are idiopathic, and in less than 10% of cases that we even can trace whatever, where it could be coming from. So the rate of the destruction of pancreatic cell is very high with them. So they are usually associated with a high level of ketosis. That's breakdown of ketones in the body. Well, let me just, I don't know, want to make it a bit. All right, so type 2 is the very common type, which most people know. Majority of people don't know about the type 1. Almost everybody know when you call of type 2 diabetes, that's the commonest one. Everybody knows that's the type 2 diabetes. Most times it's discovered by chance, or when somebody begins to have very frequent urination and some other complications. Then maybe the person goes to check. At times, during just routine medical examination, maybe school medical examination or work pre-employment medical examination, urine is tested, and he found out there's there's sugar in the urine and all that. So these ones, type 2 diabetes occurs more from the middle age and towards the elderly age. Here, the theory is that as people age, the organs are weakening, and because they are weakening, a lot of things happen. The apparatus begin to weaken too. Okay, the apparatus begin to weaken. Okay, all right. It is typically gradual onset, and many times people survive it for a long time, as long as they live. I encountered somebody who has been diabetic for 65 years, an elderly man. He has been known diabetic for about 65 years. And it is obvious in his case that if he dies, it's not from diabetes because he's managing it well. It's not from diabetes. He would have just from any other cause. Okay. Then gestational diabetes is the hyperglycemia that occurs, during pregnancy. When it occurs during pregnancy, women with gestational diabetes, they are at an increased risk of complication during pregnancy and delivery. Reason is that with gestational diabetes, what happens is that for such women, the birth weight of babies are very large. Yeah, the babies become larger than usual, and if care is not taken, there is cephalopelvic disproportion, unable to push out the baby, so it might undergo cesarean section in qualified places where that can be done. Okay, so a very high risk, and there are still other risks which is not for this class. Then the children are also at increased risk of type 2 diabetes in the future. Even those women themselves with gestational diabetes, they are also, if precautionary measures are not, because a lot of them, after the delivery, glucose level can become normal, but they are increased risk of tilting towards diabetes. So such people must be cautious. Then there is this impaired glucose tolerance or pre-diabetes. Here, it's an intermediate phase between, normal and diabetes. Just as we have pre-hypertension, it's an intermediate phase. Okay, here we can detect this when we conduct a glucose tolerance test. A glucose tolerance test is a type of test we conduct by, loading the individual with some glucose, right? Oral glucose, we call it OGTT, oral glucose tolerance test. We load the glucose, 1 gram of glucose. The person will drink. After some time, we'll begin to check the sugar level and know whether it's being controlled or not. So symptoms can be feeling of thirst, okay, needing to urinate more often than usual, blurred vision, feeling tired. People can be losing weight unintentionally. But again, one should be very careful because for non-clinicians, when you give some of this information, most of them are misinterpreted in the sense that, see, there are, for instance, weather conditions now, when the weather is cold, and because the weather is cold, people are not perspiring. And the other way people can, remove fluid in the body is through urination. So you might find out that when the weather is cold, urination can be more frequent. That does not now mean that when maybe the person begin to have fear that he probably has diabetes. No. So those are things one has to balance, and when you are in doubt, please see a doctor, because he is trained in this area over many years to advise you. Okay, over time, diabetes can damage the vessels of the heart, the eye, the kidney, the nerves. In fact, so people with diabetes have higher risk of certain health problems like heart attack, particularly stroke. People with diabetes have much higher risk of stroke than other. Kidney failure also, and even diseases like cancer. Okay, for males, prostate cancer or ovarian cancer for women. So diabetes can cause permanent vision loss. It could damage the retina of the eyes, So many people with diabetes develop problems in their feet, diabetic ulcers in their feet and all that, pressure ulcers, foot ulcers. One can be very mindful of that if care is not taken can lead to amputation. So diabetic foot ulcers can be very troubling. So because what has happened here is that the disease damages the nerves, causes neuropathy, and the individual does not feel certain pain or whatever, so that when the person hits his leg on a stone or whatever, he might not even be aware that he has even been injured. And with diabetes, infections are very fulminant, so they can lead to, and it's usually very difficult to heal. So it requires a professional to manage it. Those are not the type of wound you manage in the chemist, because the glucose level must be well controlled to enable the ulcer to heal. Okay, there are professional ways of handling them. Treatment is early diagnosis and treatment, and this can be accomplished through inexpensive testing of blood glucose, either fast test too. So people with type 1 diabetes need insulin injection for their own survival. On the most part, okay, I believe you can hear me. For one of the most important ways to treat diabetes is to maintain a healthy lifestyle, healthy balance in diet and all that, okay? At times, people with type 2 diabetes can also take insulin, depending on their condition, depending on how well their glucose is controlled or not. Because remember, I talked about insulin resistance. If such people are facing insulin resistance and all that, so there are many ways the clinicians, the endocrinologists manage them, including manage the foot ulcers, foot care, and all that. So along with medicines, to lower blood pressure, people with diabetes need medications to lower blood sugar and statins to reduce risk of complications, okay? So prevention, 2 ways. One, to help prevent type 2 diabetes and its complications, people should, 1, reach and keep healthy body weight. Healthy body weight is very important. Checking the BMI so that body mass index is within normal value. And staying physically active, I've told you about 150 minutes of moderate exercise each week. Eat healthy diet, avoiding sugar and saturated fat, and avoiding smoking. Then take us to cancers. Okay. Cancers, by definition, is a generic name. Cancer is actually not a particular disease. It's a group of diseases. You know, it's a generic term for a group of diseases that can affect any part of the body. Any part of the body, although some parts of the body are known to have almost not affected by cancer. A typical part, body part is the heart. It's a rare occurrence. So rapid cessation of abnormal, rapid creation of abnormal cells that grow beyond their usual cell boundaries. Normally cell growth is regulated in human body. So yeah, for instance, the fingers cannot grow beyond their boundaries. It's regulated. There are hormonal regulations that are genetic. Okay, but if cell growth begin to exceed normal body boundaries, then those growth, they are abnormal. They are abnormal cells. Okay, they are abnormal cells. So when they begin to outgrow and invade adjoining parts of the body, they are spreading to other organs. You will know that a malignant growth or a cancer is in the offing. There are two types, the malignant tumors, or another name for these tumors is neoplasms. You know, new formation, neoplasms, or benign tumors. Benign tumors are not as harmful compared to the malignant tumors. From the word malignancy, when you say something is malignant, it's, benign is calm, So benign tumors are not malignant. They can displace organs, they can occupy space, but once they are removed, nothing thereafter, no consequences. So these are the commonest cancers. In men, you have the lung cancer, followed by prostate, colorectal, stomach, and liver. Then in women, you have the commonest is the breast cancer, then colorectal cancer, lung cancer, cervical cancer, and thyroid cancer. These are the key facts, number of persons affected in different parts of the world globally, and the number of deaths it leads to. Let's skip it for time's sake. So cancers arise from the transformation of normal cells into abnormal cells or tumor cells in a multi-stage process that generally progresses from a precancerous lesion to a malignant tumor. So these changes are the result of the interactions between a person's genetic factors and three categories of agents, external agents. The genetic factors interacting with physical carcinogens, such as ultraviolet rays, ionizing radiation. These ones, because of skin cancers, cancers like squamous cell carcinoma of the skin, basal cell carcinoma, and different type of skin cancers. Okay, then chemical carcinogens like asbestos. Asbestos is very carcinogenic. And if you observe, you see that it's now less in use compared to, formerly we had a lot of asbestos roofing sheet and all that. But because of this problem, its use is reduced. Components of tobacco smoke, aflatoxin. Aflatoxin is a food contaminant. It's a fungal infection that contaminates when food are stored, like, say they stored in grain reserve, national grain reserve and all that. If not well prepared, preserved, this fungi that produces aflatoxin can contaminate grains and all that. Then arsenics. Arsenics can occur is on the soil, it can contaminate underground water sources. You know, these days we put boreholes everywhere because we don't have municipal supply of water. So everybody is a local government. Everybody supplies its own. Many times people don't even test to know the chemical component that could arise from their borehole. Then biological carcinogens such as some viruses and bacteria that are known to cause cancer. You know, another risk factor for cancer is aging. Aging is a fundamental factor, and because incidence of cancer rises dramatically with age, and it's as a result of a build-up over the years. The overall risk of cancer with aging is quite high, and the part of the problem is that the process of cellular repair because of defective metabolism that occurs with aging. You know, normally when cells are damaged, the body has a way of repairing them and they go back to normal. But with aging now, those functions are gradually being lost as people get older, as they become gradually weakened and lost, then, you know, anything can happen. Here again, the risk factors are the same: tobacco use, harmful alcohol use, unhealthy diet, and physical inactivity. Again, they can be then, there are some bacteria that are known to cause cancers. Helicobacter pylori, human papilloma virus. There are some serotypes of human papilloma virus. Hepatitis B, for instance, hepatocellular carcinoma, hepatitis C, Epstein-Barr virus, you know, Helicobacter pylori, stomach cancer, and all that. So some of these things can cause cancer. HIV is substantially increased risk. Infection with HIV substantially increases the risk of cancer, such as cervical cancer. Not only that, Kaposi sarcoma. Kaposi sarcoma is a cancer of the skin that is found in those that are highly immunely depressed. Okay, so prevention offers the most and cost-effective long-term strategy for treatment of cancers. So we can have that from policies like banning or limiting the use of tobacco and all that. Okay, there are many ways. Tobacco is particularly so dangerous that there are more than 7,000 chemicals in them. At least 250 are known. So tobacco is particularly very dangerous. But when we are very insensitive in the way we do things in our society, well, at times you will say, will you even stop our people? I can remember when civil society organizations in Nigeria were very angry with the Nigerian government for granting BAT, that's British American Tobacco Company. They have their biggest factory, I think, globally, in somewhere in the West, in the other Ibadan area, you know, during the regime of Obasanjo, and granted them because so a lot of tobacco is being produced in the country. But our policymakers, of course, do not appreciate the enormity of their actions anyway. So that is it. So physical inactivity and all that, obesity, they are linked with some form of cancer, cancer of the esophagus, colorectal cancer, breast, endometrial cancer, and the rest of them. Harmful use of alcohol, again, cancers in the oral cavity, pharynx, liver, colorectum, breast, okay, and the rest of them. So infectious diseases, hepatitis B, hepatitis C, human papilloma virus, we mentioned them already. Okay, occupational carcinogens. There are some cancers that take place in the occupational setting, right? So, and that is why employers of labor must ensure that they protect their workers But better still, the workers themselves must ensure that their lives are protected. It's not only about agitating for salary increase. They should also ensure that they are agitate about their safety, because many employers are shylocks, they are not bothered. Cancers like mesothelioma is a cancer of the pleura or bladder cancer. Cancer of the pleura, mesothelioma, is caused from exposure to asbestos. Cancer of the bladder, rubber products, and certain resins. You know, there are a lot of them. So then some are for radiation workers, exposures to radiation, ionizing radiation and all that, too frequent exposures. For instance, radiological investigation, radiographers, radiologists are at risk of such cancers, but in their own case, well, they are protecting themselves from exposure. You know, they adopt time-limited exposure, but if anyone is careless with himself, well, sorry. So for cancer, what is to be promoted is, one, prevent the healthy lifestyle, then early diagnosis and treatment. The reason for early diagnosis and treatment is that it is known that all forms of cancers are completely curable if they are detected early. You know, so screening programs, if they are detected early, can solve the problem. Then other ones are chronic airway diseases. These include asthma, respiratory allergies, obstructive pulmonary disease, COPD, occupational lung diseases, sleep apnea, and pulmonary hypertension. There are a lot of them, but these are four just mentioned here. They account for a lot of deaths among humans. The most vulnerable people for these ones are children. Indoor pollution with fossil fuel, firewood, coal, indoor pollution. Children are very vulnerable to them. Premature deaths and disabilities arise from these. They are also preventable if those factors are recognized early and removed. See, so most of them are actually preventable. Okay, this is just a diagram showing, you know, how this spread up to down to the alveoli. Okay, indoor air pollution. The poor woman is making firewood to find food for her family, but the child is at the receiving end of, unfortunately. And look at the young boy, of course, excitedly going to his school, and see how polluted his environment is. All right. So prevention is to track make a surveillance, so that we know what's going on. Because if we don't know what's going on, we'll be careless. It's like we don't appreciate the enormity of the problems around us. So that's why it's necessary. Don't worry, I'll answer questions. Just question, when we finish, they will ask me questions, I'll answer. Okay, so we have primary prevention, personal exposure to risk factors, avoid direct tobacco use, or indirect tobacco. That is the one they call passive smoking. Passive smoking, you are not smoking, but all your friends are smokers. Therefore, you are a smoker, because once they are smoking, you are also smoking, and you are at the same risk with them. You are at the same risk. I'm telling you, you are at the same risk with them. So address low birth weight, poor nutrition, acute respiratory infection, and all that. Okay, I think there are just so many. Maybe I shouldn't have loaded it. Let me see how many of those are still left. Okay, we've gone far. Okay, here we have sickle cell anemia. sickle cell anemia is a genetic condition that is usually present from birth, and this occurs when there is either a marital or relationship between two people with whose genetic positions are risk factors, ASAS. Okay, when they have that, used to the risk of having SS children are there. With two AS people get married, it means about 50%, the chances are, the probability or the chances are that 50% of the children will be AS, 25% will be AA, another 25% will be SS. That is mathematical probability. But that is, if you look at it, you say if they have 4 children, 2 will be SAS like them, not physically sick. 1 will be SS, 1 will be completely healthy. But in practice, in nature, that mathematics does not work like that. I've seen a situation, somebody has 4 children and all of them became SS. The person can have 4 children and all of them becomes AA. So it's a game of chance, probability of occurrence. It's a chance. So can you afford to take that risk? That's the question. That is why premarital screening is important. But I know that when people are deeply in love, they'll say, God forbid, or God will not. But if you mention it, you become a very bad person. That it's like you are wishing them, although that is the way Africans reason. So me, I understand that for a long time ago. So those of us who are medical doctors, we are very careful to tell people, particularly when we are in church, they embarrass us a lot as if we are the people that cause disease. I cannot use my money to service negativity. I went to hospital, the doctor this. I mean, just as if the doctors invited them to the hospital. They took themselves to the hospital. They could have remained in their houses, And the doctor I went to the hospital, the doctor told me, I said, I reject it. Then why did you go there in the first place? These are some of the things when we become too religious because of ignorance. It's a lot of problem for those of us who practice medicine in Africa, because of the limited knowledge of our people, So when you tell them about, they will not agree, okay? And some pastors will begin to quote Bible and all those. And when it happens now, then all right, so let's go on. So people with sickle cell anemia, normally their blood cells become sickled. It's a sickle. That's a shape. Okay, I think I didn't. Okay, yeah. Let me see. You see what a sickle shape is. See what the normal blood cells look like. And when it becomes sickle like this, it cannot transport oxygen. It can no longer transport oxygen. So because the blood is sickled, it cannot transport oxygen, then that leads to anemia. So the children are very anemic. It's an inherited trait from both parents, okay? The pattern of inheritance is autosomal recessive, it's not a dominant, it's autosomal recessive. So this is just what I've explained. If an AS meets a male AS, female AS, 50% are AS, that's 50%, this and this. 25% is SS, 25% is AA. That's mathematical, this thing. Okay, so it is believed that sickle cell disease arose from genetic mutation against malaria because it is found only in Africa. It's found only in Africa, and theoretically it is believed that it's a mutation as a result of malaria predominance in Africa over years. So it's a defective hemoglobin, and once the hemoglobin is defective, now its ability to carry blood, convey blood to vital organs and tissues become diminished. So they become sickled, they can no longer this. And when they become sickled, they are no longer pliable. They can no longer navigate their way through tiny blood vessels. Instead, they get there and got stuck and block the blood vessels. Okay, and you see, so you can see sickled ones. See how the normal blood vessels, when it gets to a narrow place, it will just squeeze in and that's the normal blood. But look at sickle, when it gets to a narrow place, it will just get stuck there, and the oxygen can no longer be supplied to the external tissues. They begin to die. So, okay, say, look at what a sickled cell look like. This is a sickle. This is what the normal red blood cells. Here, it can carry attached oxygen molecules and move around. These ones, because of the way they are, they cannot attach oxygen molecules to themselves. So sickle cell anemia is characterized by low number of red blood cells. They are easily destroyed. The lifespan is 10 to 20 days. Okay, that normal biconcave, normal cells normally releases oxygen and maintains it by concave cells, okay? But deformation due to that sickle cell makes them unable to do so. Okay, see, you can see it is illustrated here. Under normal condition, it could, but here it can no longer. All right, so how does it affect? It affects a lot of children in Africa and even Africans in diaspora. Okay, Africans in diaspora, even those of African Americans. But in the other countries, and like in the Mediterranean and all that, we have a different type of sickling. Okay, a different type of, called thalassemia. Although that is not our focus. Just here, the patients are anemic. Most times they are dizzy, appear to be fainting when they are under crisis, shortness of breath, very pale, the extremities are cold, headache, chest pain, and all that. And very importantly, pain. Sicklers undergo severe pain, and those pain is as a result of blockage of tiny blood vessels that does not allow oxygen to move those areas. So it causes a lot of pain. Children can have respiratory distress. So the complications can be stroke in children with sickle cell. Yes, gallstones, gallbladder stones. There's something called splenic sequestration. I don't know. Well, sequestration of blood is just pooling of blood into the spleen. The spleen will be seriously enlarged and can lead to what we call avascular necrosis of the femur of the head. Then ulcers, leg ulcers, priapism can happen. Priapism, well, some of you might know what priapism is. Some form of erection that does not respond to any form of stimuli. When you have such, suspect the person to have sickle cell disease. The erection remains persistent because normally when erection takes place, blood flows in and flows out. But because of the blockage, it goes in and unable to come back, and it becomes, when the blood vessels in the kidneys are occluded, it could lead to renal failure, and several other things, retinal damage and all that. Okay, prevention, one, screening, counseling. Prevention, primary prevention, prevent birth of an affected newborn. And how do you prevent it? Check your genotype. Okay, secondary prevention, here, manifestation of signs and symptoms. You identify the signs and symptoms early and treat. Then tertiary, treat for complications, and rehabilitation. We do screening, population screening, in order to identify cases of sickle cell, which is very important. We do genetic counseling if they were here, and that is that. Then the other one, I think this should be the final one, is road traffic accidents, another major non-communicable disease in our society. It is very common. It is very common. WHO defined it as an unexpected, unplanned occurrence which may involve injury. Okay, but not everybody agrees with this definition, because this definition tends to make accident as if it is something unexpected, something that maybe happened by providence, maybe God ordained it to happen. No, because all accidents are avoidable, all without exception are avoidable. And because they are avoidable, it cannot be unexpected or unplanned. That is why many authorities are in disagreement with that definition. So in some countries, like in the US, it's called road traffic crashes. Crashes in the sense that when you say an accident, you are presupposing that it's something that will occur beyond your control, but we are saying that it is within your control. Every facet of it is within your control, so however, that's what WHO advisory. However, there's another definition that says an accident is the occurrence of a sequence of events that usually produce unintended injury, death, or property damage. Okay, there are a major epidemic of non-communicable diseases. As I said, some people currently don't consider them an accident because they feel they are the choices we make. They are choices. All right. In Nigeria, let's come home. In Nigeria, it is very common. It's very common in our country. It's not only in our country, globally it's common, but it's worse in developing and low and medium income countries. Now look at this last bullet. Say 93% of world fatalities on the roads occur in, imagine 93% as high as that, low and medium income countries, even though these countries have approximately only 60% of world vehicles. And in terms of demographics, it occurs most among young children and young adults. Young children and young adults, then more in males compared to females. So this is Nigerian data. We have about 33,000 thereabout deaths per 1,000 population. Most accidents from a survey done by National Bureau for Statistics in 2017, October 17 and 18 show that the greatest cause is speed violation, speed over speeding, about 44%, just call it 45% over speeding. Then tire bursts, the over speeding with used tires, so these are some of the problems. Used tires, over speeding with used tires. Okay. Then others are dangerous driving, dangerous overtaking, or wrongful overtaking, brake failures and all that. So so all this talk about poorly maintained vehicles. So they are not, people they are all managed. They are all manageable. That is why I'm of the school of thought. I believe I will align my thoughts with those who say they are preventable. They are all preventable. So there are factors that are responsible. Three major ones: host, environment, agent, and environment. The host factors are the individuals. The agent factors are the vehicles. The environment factors are the road signs, and all that. I'm sure you would have read that. So host factor of age as a host factor, as I said, commonest, deaths are commonest, injuries are commonest among the demographic group of young children and young adults. And more in terms of sex, more in males than in females. Young children, because most vehicles don't have seat belts for children. The restraints for children are not there. You have it for adults, but you don't have it for children. So parents are supposed to buy the children's seats and anchor in, but most don't have it. Most don't. So that's a problem. Then in terms of socioeconomic status, 90% of the road traffic accidents occur in low and medium income countries. Okay. And African region has the highest death rate from road accident. So in terms of socioeconomic status, that's how. Non-use of seat belts, non-use of motorcycle helmets, and all that. Recently in town, you see a lot of delivery people, they crisscross the town. Most of them are without helmets, and they are so rough at, as if they have their life in their own hands. So putting up of seatbelt, for instance, reducing deaths from road accident by at least 25%, so that's very good. Any increase in average speed is directly proportionate to a crash that will occur. So for every 1% increase in the mean speed, produces at least 4% increase in the risk of fatal accidents. So every 1% increase in risk increases risk of fatal accident. You see, so driving under the influence of alcohol is also another important aspect of a host factor, because they say when you drink, don't drive, and when you drive, don't drink. But people violate all that. Normally, road safety is supposed to have, do have this equipment they call the breathalyzer that can monitor the blood alcohol content. But many times, many times they don't, do that. Even if they see the person is, they just collect something and the person goes. Distracted driving, typing or making calls while driving, that can also be a major problem. Then other host factors, lack of experience in driving. When people don't understand the road signs and lack experience or have defective judgment while they are driving, maybe they want to overtake and it's not appropriate for them to overtake, and they still go ahead because by their sense of judgment, they can overtake, but in the real sense, it's not appropriate. Then the agent factor here is about the vehicles. Old and expired vehicles, poorly maintained vehicles, old and expired tires, overloaded vehicles, broken side mirrors, lack of traffic indicator lights, dim headlamps, and so many of them, malfunctioning brake system, unavailable seat belts, lack of caution signs, the one popularly called triangle. I've seen a lot of trailer will park on the way without those caution signs. The following morning, you see a vehicle ram into them. Absence of fire extinguishers, lack of screen wipers, particularly now during the rains. Some people are driving without screen wiper. They will drive, they will stop, they use their hand, such. Then environment factors, defective and narrow roads, congested roads. The same road, motorcycles, keke, pedestrians, cows, everybody on one same road, congested road. So it becomes survival for the fittest. Indiscriminate erection of speed breakers. Those speed breakers, they destroy the roads. You just observe, anywhere you see speed breakers, the road will start getting back from that spot, right? Because as the cars come up, they bounce, they keep on hitting at that point, it gives way after a while. So poorly lit roads at night, most times the roads no lights and no street lights. Okay, lack of traffic signs, zebra crossing. As for zebra crossings, even when they are there, they are not obeyed. It's like our people don't even know what it is. Maybe they think it's fancy, I don't know. Because I've seen people try to cross the zebra crossing, vehicles almost took their life on the zebra crossing. So I begin to wonder. Then weather issues, heavy rainfall. It's advisable not to drive when the rain is very heavy. Usually it's a few minutes. When it becomes very heavy, in a few minutes, it subsides. So people are advised to park if it's too heavy, you know. So that's that. And prevention, seat belts, vehicle maintenance, always, regular vehicle maintenance, regular road maintenance, and enforcement of road signs and regulation. Thank you very much. That's the end. Let me answer your question. So you can unmute yourself and ask a question if you have. Okay. Thank God the network did not give too much problem today. If you have any question, please, yes, you raise your hand. Faith, Franklin, go on. Emma Motimi, then Beauty Maxwell, Toby. Is it
Okay,
Beauty?
good evening, sir.
Yes. Good evening.
Thank
Go
you
on.
very much for the lecture.
Thank you.
So actually, I have two questions. My first question is regarding the hypertension. So I want to ask if pregnancy can be a risk factor to hypertension, because sometimes we see this pregnant women, immediately they just get pregnant, the blood pressure will just start going up, and maybe immediately they remove the baby and all that, everything will turn back to normal. That's one. Then second question is about the sickle cell. I'm trying to counsel a patient, and the patient told me that a doctor said that there's actually a medication that can suppress the S. So I don't know how true that information is. So I just want to confirm. Then lastly, if a bone marrow transplant will be able to solve the problem of sickle cell.
Okay. Okay, let's answer the questions. The first question is about whether pregnancy is a risk factor of hypertension, or the other way, or hypertension is a risk factor of pregnancy. Your observation is right. Hypertension, blood pressure can increase in pregnancy. If it is mild, it's not an issue. You also observe well when the woman delivers, it goes down, all right? That is not an issue. It does not say that that woman is hyper, but the thing is that for any woman that is beginning to have severe hypertension in pregnancy, we call it maybe eclampsia, then there is a potential, there is a larger risk that such a woman will develop hypertension. For such cases, the theory that hypertension, particularly in pregnancy, it comes from the kidneys. There could be some form of deficiencies in the kidney. That is why it occurs, right? So the person must be careful with the kidneys. Then the other one about a drug to suppress the S genotype. I don't know about that. I don't know how. So what now, if it suppresses what, I've not heard about it. Maybe it's there, I don't know. You know, science is developing every day. I might not know everything. Then the issue of bone marrow transplant, yeah, the technology is there, but can you afford it? It's not available to everybody. The technology is there. The bone marrow transplant is there. It's a new technology in some countries, yeah, but can you really afford it? Do you have access to it? That's the problem. Thank you. Beauty, Tobin. Is it the beauty I know? Go on. Your mic is on.
Yes, sir. Okay, thank you, sir, for the elaborate lecture. Sir, I don't know, I'm wondering, the analysis you gave concerning the cancers between male and female, the occurrence for female. I was thinking after breast cancer, the second one is cervical cancer. But you wrote colorectal cancer. I don't know if it has changed. I was just wondering.
Okay, well, it's generic, different environment have their different this thing. For us,
Uh-huh.
after breast cancer, we have
Cervical.
cervical.
Yes,
Then
okay.
for us, yes, in
So
Nigeria.
this statistics is for the Western world.
Yes, exactly.
Okay, thank you, sir.
All right.
I don't also know whether there is still room for us to learn the standardization.
Okay, if you want
It's
now,
I'm
sure I gave you people the slide.
you gave us the slide, yes,
It's
but
not
it's not there that yet.
okay.
Yes,
I
sir.
give you,
Thank you,
all
sir.
right. I
Thank
think
you, sir.
it's all right. The problem is the time now. Most times, when I didn't even want to, only few people want to come to serve. All right, thank you, Yunusa. Thank you, Ibrahim Yunusa. Go on. Ukwezi Lovina. Ukwezi Lovina. Kelvin. Go on now. You
Yes, sir.
Yes, go on.
Lovina, sir.
Okay,
Thank
go
you.
on. I can
Thank you
hear
for the
you.
lecture.
Thank you.
Okay, please, can you throw more light on which one is more at risk between the systolic and diastolic blood pressure, and
Which is
which one is more at risk between the systolic and the diastolic blood pressure, and
that you
at
came.
what range?
I know that I'm not answering
Consider
that
it
question because
high.
you came late. You came late. I've said something about this before. So you came late. You can't join anytime you like. Tell me to throw. I'm not throwing anything. Next question. Why I'm saying so? Because I mentioned this for any person who was here would have answered, know that I mentioned it. So you can not come anytime you want and ask me. I should go back.
I
Next
love
question.
Hello,
You say
Prof.
what?
my internet had issue.
Your internet had issue. All right. I said both of them are important. Both of them are important. But the systolic pressure, systolic pressure is talking about the pressure in the heart when it is contracting. And when the pressure in the heart, when it's contracting, is very severe, it could cause a lot of damage, like hemorrhagic stroke, like myocardial infarction, very huge pump, and there will be a burst. If you see, I have seen at autopsy how the heart busted like a burst tire. That could all be caused by systolic pressure. But diastolic pressure, in the sense that in monitoring control, for instance, you need the diastolic. With the diastolic, you want to see under which pressure the heart, under the magnitude of pressure the heart is consistently on, even when it is said to be relaxing. So both of them are important, but for me, the one that could be more dangerous, that can be more catastrophic at times, is the systolic. All right, thank you. Kevin.
Good evening, Prof.
Good evening.
Yeah, Prof. Yes, when you were discussing about the causes of the cancer, you mentioned aflatoxin as
Yes.
chemical cause of cancer.
Fungal,
Yes, but I just want to Yes, I just want to confirm. The aflatoxin is caused by a virus, by a fungal infection, a fungal, yes.
Fungal,
So,
yes.
and then you also mentioned about biological causes of cancer. So, and you
Yes.
mentioned other things like fungal, virus, and the rest. So, if fungi can actually produce that aflatoxin, are we not, will I be wrong if I still include the aflatoxin as a biological cause of cancer, since it's being produced by a fungi?
Well, because it's a chemical, actually. Yeah, I agree with your reasoning, but it's a chemical. It's a chemical agent, though it is produced by some set of fungi. So, was it classified under chemical?
Yes, yes.
Yeah,
And it's produced by Aspergillus flavus, a fungi.
yes. Actually, that's how it is produced. But well, you know, in science, everything is argument. If you can prove your own, I agree with you. But that is what you can go
Okay,
and check more of
I'm just
aflatoxin.
asking for exam purpose, actually.
I know you can go and check. Okay, go and read about aflatoxin now.
Okay,
You can
okay.
see, just look through. Find in books, you see about aflatoxin to learn, right? You know, I'm not an
Okay.
expert on aflatoxin. I just know it also sparingly, you know. Okay, so you can find out more about it, and let's see where it will be
All right.
better classified. Just read about, you know,
All right. Thank you, sir. Thank you, Prof.
aflatoxin. Yes, you can. It's aspergillus, yes, and aspergillus they are fungi. Ideally, I think it should actually be in biological, really. Okay, let's have. Was it David that spoke with me?
No, sir.
Okay, David. After David, Aisha Bawa. Then Okeke Leonie. All right, David, go on quickly.
Okay.
After you,
Good
Aisha.
evening. Good
Yeah,
evening, Prof. Thank you
good
for the
evening.
lectures.
Thank you.
All right. I'd like to ask concerning the cancers, because you mentioned strategies,
Yes,
yes, to try to curb cancers. But speaking from what I've observed, I don't
yes.
know what's your take, because I don't think the strategies are working. I think the emphasis is more on early diagnosis and treatment. But you notice that most patients with cancers come in most times in a fairly advanced state
I
of cancer.
agree. Yes.
Yes, and yeah, so I don't know what your take will be concerning like a proper approach for the prevention. And then secondly, I also noticed that one of the reasons for the late presentation there seems to be a lot of groups now. You find them on Facebook, you find them on WhatsApp, and preaching what they call it, preaching herbs, natural remedies for cancer cure. And even when some of these women, or let me use the women because breast cancer is one of the commonest. The women find out, they discover these things early, they still get misdirected, if I'm to use that word. And that way, by the time they finally find their way back to trying to get proper treatment, you find that they're already in an advanced state. I don't know, is there is a way, or is it possible to take measures or to enforce, trying to stop that? Will it be against the people's rights, like to stop those kind of groups that are creating those misconceptions?
Thank you very much. You touched some very passionate, you raised some very passionate issues. Yes. First, let me start with the first one. I don't know if you're a clinician. You know, for me, my specialty is preventive medicine, right? And preventive medicine arose from clinical medicine. That's why I'm still a clinician. I will still belong to Faculty of Clinical Sciences. Now, you will find out that if you observe in our healthcare system, you say that the strategies, you somehow disagree with the strategy, and you are very, very 100% correct, simply because of our priorities, which are misplaced. You don't see us paying much attention to preventive care. Even our people, so even if the healthcare system, the government want to even pay attention to preventive care, our people as individuals they do not, I don't know, they are not in tune with preventive care. The only language they understand when they've seen it manifested, then they start panicking. They start panicking. You know, when somebody is smoking, when you are telling him not to, say the first thing you will tell is, what will kill a man will kill a man. You know, so people, it's either there are so many things involved here. Level of ignorance, misunderstanding of religion. I don't know whether I put it that way. Culture, there are so many things. It's a gamut. So it's difficult. People don't, it's just take, for instance, health insurance. People don't see reason why they should pay for health insurance because they are healthy today. You know, they don't see the reason. They don't know that in the long run it's far better. No, they don't look at it that way. You know, so that is the problem. So you are right in that way. The healthcare system has disemphasized preventive care because the people themselves the people who are running the healthcare system are not even interested. Many times, those who should run it, if they are surgeons, for instance, the surgeon, all he's talking about is how to take his knife and go and cut or you. So that's one misplaced priority. Then the other issue you talk about, the media space. You know, when we started by defining health, everybody has a definition for his own. In Port Harcourt, I don't know if you're in Port Harcourt. In Port Harcourt, where I am, several prominent boss, if you go to Rumoko, you just say, come and see gonorrhea, see the waka, they go. Come and, charlatans are giving free air, how do you call it, to say anything. But the qualified people like doctors are highly regulated. If you say anything, they call it advertising. In fact, your license can go. But charlatans come to the TV and tell you that gonorrhea is caused by staphylococcus. This person has mentioned 2 bacteria that have no relationship with one another. But the public is being fed with such wrong information, and everybody thinks it's good because it's freedom of speech, or how they call it. And nobody makes any attempt to regulate it. So whatever we get, we see, we take. Any person will die, go, come next time. That's it. Next question. So that's it. That's how we are as a people. It's part of our development, I believe. That's part of where we are in development today. Maybe in the next 200 years or 300 years, the Nigerians at that time might be better, who knows, or worse. The way they are going, are you sure it's going to be better? I doubt. I have my doubts. So that's a problem. Charlatans are allowed all the airwaves to say any trash, deceive the people. And you rightly observe that they come at the last stage. Somebody told me that this one, a hospital self, people too die. Why would they not die? I told him that they came dead. As far as I'm concerned, they have died before they brought them. Because they have gone every other place. And when it did not work, they now say, when the person has started breathing once, after 1 minute, you now breathe another one. Then they say, come and go to UPTH. And when you go there in 2 days, the person will die. So they will quickly announce he died at the University of Port Harcourt Teaching Hospital. No, he has died long before now, either in all the places they went. Before you complete investigation, the person has given up. And they spent all their money By the time they come, you write the smallest prescription they cannot afford. You put for this investigation they cannot afford. Because the charlatans have collected all the money from them with sweet mouth. At the end of the day, they are done. All right, Aisha, go ahead.
Good evening, sir, for this wonderful presentation.
Thank you. Good evening.
Sir, I'm calling all the way from Katsina
I'm
State.
not seeing the emojis. People are laughing. Not true now. You know now. Go ahead,
Yes.
Aisha.
And sir, my question is regarding the respiratory disorder. You made
Yes.
mention of those smokers and their friends. They are
Mhm.
almost at the same page.
They are
So,
the
sir,
same thing.
yes, sir. So please, I need more highlight over that.
What happens? The other is called second-hand smoke or passive
Okay.
smoking. It's called
Okay,
second-hand
sir.
smoke or passive smoking. The important thing is that the person is inhaling the tobacco in the process, right? It's as dangerous for that person as well as at the same level of risk for the person who is smoking. In fact,
Okay.
it happened in my hospital. A very prominent professor died of
Yes, sir.
lung cancer, a female, and we were worried how and all that. Later, we
Okay.
found that the husband was a chain smoker, but the person that smoked did not die. You know, so that's how life can be. At times it can be unfair. You know,
Yes.
yes. So it
Thank
has the same measure of risk. Yes. Okay,
you.
okay.
Thank you, sir.
This is Sochuku. Yeah, you're welcome. After that, Charles Oliver. Unmute yourself and ask your question, please.
Good evening, Prof, for the class.
Good evening.
My question is on diabetes mellitus. I've
On,
seen a child. My question is on diabetes.
okay.
There was a child that was brought to the hospital, and after diagnosis, it was found out that he has neonatal diabetes at the age of 6 months.
Yes.
So my question is, what actually is the cause of the neonatal diabetes for
That will be very
an
simple
infant of
now.
6 months?
Pancreas did not develop well, so unable to produce insulin. Such child is, even that neonatal, is type 1 diabetes. Because, you know, the beta cells, the B cells, remember from your basic physiology, that produces insulin. If in the time of formation and, you know, poorly formed, unable to produce insulin that will metabolize blood glucose, then that's that problem. So it's very possible. It's very possible. Okay, so that child will be on insulin. And that is why, you know, you have a pediatric endocrinology. That's what consultant pediatric endocrinologists treat, you know. So these studies are going, you know. The important thing is that when they go to the right person, the right professional, they can be helped. And the child can live well. Okay, Charles D. Oliver. Yeah, unmute yourself. Or Confidence Mori. Confidence Mori. All right.
Okay, thank you, Prof.
All right.
My question is,
Go ahead.
okay, my question is, sir, can you describe this ischemic and hemorrhagic stroke as in their characteristics? How can they be identified? Thank you.
To identify them, if you want to identify it, you know, this pathological, you can identify it, you know, histopathology, you can. But the characteristic is simple. If it is hemorrhagic, you know, if it is hemorrhagic, what happens is that the blood vessel got burst, and the blood spilled intracranial, maybe it depends on where the blood spills occur. It can, it can lead to many things. But on the other hand, that is if it's the blood vessel busted or burst and the blood spilled into the cranium. If it is ischemic is that blood are denied oxygen. And when they are denied oxygen, they die. That is the ischemia. That's what is called ischemia in pathology. They die. And when they die, that area begins to rotten. Then you have the other aspect of stroke. But clinically, well, this is not a clinical class. We're going to have to identify the truth. You are not going to do a blood or CT scan. Maybe you do a CT scan and see, and no. Computerized tomography scan. All right, next, cause rep, counselor. Your hand is raised. Go on. Swakelo. Okay, if you are not there, someone else. Is Charles Oliver there?
Okay, sir. Sir, I'm available. I don't know if you can hear me.
Yes, I can.
I'm so sorry. Thank you for all you do, and thank you for the wonderful lecture. I really appreciate everything. But today's lecture, I'm kind of away. Be very good with it. But that yesterday, I intended to ask a question, but lecture and the place I work. So I want to take us back to when you were talking about malaria and the resistance yesterday. I know recently I've always been down with malaria, and this time I think malaria almost every month. So it got to the point that I got to worry.
It might be AA group.
Yes, I know. I belong to that. Belong there. I belong to that genotype. But I was so worried, dog. Sometimes there's a way you do it, and it will start becoming alarming. So I asked the doctor that was attending to that, has been always attending to me. So he said the way he's seeing it, that it's not actually that my genotype and my blood group, but that he's also seeing that recently that malaria has developed a resistance against some of the drugs being used. And I asked him, so what drug is that? So he was like, it's not only about the drug, but about the active ingredients used in making of the drug. So I was, what active ingredients? So he told me about artemether and then lumefantrine. So I was, okay, fine. So if malaria developed this, so what method can we use? So he was asking me, he was telling me that he would have used chloroquine for me, but he does not know how my body will react to it. So I said, okay, fine, go about it. And I truly acknowledge that for sometimes now, okay, like throughout the whole of this month, I haven't been down. Throughout the whole of last month, beginning of last month, coming to this month, yeah, I'm somehow fine, strong. So I don't know. I don't know if you are aware of this. Is it true that really malaria in Nigeria, because you are still practicing and you are a clinician, like I can describe the heart. So I don't know. I want to know from you if truly malaria has developed resistance against these.
Okay, let me tell you, we don't have, let me just answer it directly. We don't have widespread malaria resistance. So isolated cases possible, right? We don't have strong evidence. Nigeria is not classified as one of those countries where But let me tell you what would have happened. What would have happened in this particular case you are mentioning? There are a few things. One, not all cases of fever is malaria. So some of your fever might be misclassified. It might not be malaria. Okay, not okay. That is one. Two, a lot of the drugs are substandard. So that when you take one drug, you find out that you have just finished taking this drug, and a week later, you're almost feeling as if you are going back to the same this thing. You are advised to take another course. That is true, because most of them do not have the full component of the ingredient. When I was in management in UPTH, when we do our drug procurement, we sample the drugs to see the content of active ingredient in them before the pharmaceutical companies can supply them. In fact, at that time, we put our benchmark that if any supplier has up to 80% active ingredients, then we are good to go. Because to get more than 80% is like they cook it in the fire, right? So many of the drugs don't have that, they are substandard, let me put it that way. They might not be completely fake, but they are most are substandard. They don't have that very, this thing. All these, particularly the imported ones, they are substandard. That is second. Then thirdly, check your absorption. Most of those anti-malaria drugs are oral. It is always good when you are taking drugs to look at the prescription, the leaflet properly. There are some drugs you are asked to take it on empty stomach. Some drugs you are asked to take it with food. Okay? There are meaning to each of those things. If there are some drugs is best taken on empty stomach. The reason is so that there could be maximum absorption. Not if they are the drug you are supposed to take with food, you load your stomach with one mighty heavy meal and drop one tablet or 2 tablets, and it fizzles out. Blood concentration is low. That is on one part. On the other part, are you somebody with hyperacidity? Are you, tending towards, are you, an ulcer patient or hyperacidity? Let me just put it hyper, not necessarily ulcer. Such people, your absorption rate is not as good as. So instead of going to give you chloroquine or anything, you should have tried at a meter injectable so that you bypass the stomach and get straight to the bloodstream, not to use chloroquine. That would have been my advice. So that you use the injectables. Maybe your absorption is not very good. If your absorption is not very good, in that case, you are not absorbing much of the drug. Then it becomes a problem. You begin to treat it repeatedly. Okay, that's all I can say. Then, okay, that's all. Chioma Evelyn, I hope you had me. Oh, the network, I'm not sure he had me. Oh, sorry about that. Chioma Evelyn Olaoye, go on. Our time is gone fast, so that we can. Or Cyril Wale. Cyril, go ahead. Oh, somebody can't unmute. Sorry, I don't know what's happening. Maybe you go out and come back.
Prof, I can unmute myself now. Good evening, Prof.
Okay, go on. Go on.
Thank you for the lecture. And my question is on the sickle cell disease. I know that somebody who is AS has one normal hemoglobin gene and then the sickle cell
Somebody who
gene.
is there.
So my AS.
Yes.
Okay. So my
Yes.
question is, what does the sickle state blood cell mean for a person who has one copy? that they experience milder symptoms than somebody who has 2 copies, that's somebody who is SS and somebody who is AS.
Please repeat the question. I didn't get a bit more food.
Okay, I said, what does the sickle cell shaped blood cell mean for someone who has 1 copy as somebody who is AS? Do they experience milder symptoms?
Nothing. If the person is AS, one person AS is just a sickle cell trait. You know, the person is normal, it's a trait. But it becomes a problem when that person meets with another person. So the product is where the problem can now be. Not the 2 traits have no problem. The 2 people, the man and the woman who have a sickle cell trait, on their own, they are normal people, they are healthy. But their offspring can have a chance. If their offspring becomes a sickle cell trait, thank God. But if their offspring now, becomes SS, that's why the problem comes. But the trait has no problem. It's just a trait. Okay. Geraldine Ugu. Then Jane Abba.
Okay, good evening, sir.
Good evening.
Thank you so much for today's lecture. Please, my question is, yesterday lecture, I was trying to ask questions, but I couldn't. Okay, please, when we are talking about vaccine, I asked if BCG, that is, if you give birth, the 0 dose of hepatitis 0 dose, how long does it last on the baby? And does it contain both hepatitis A, B, and C? And how long does the lifespan last? Thank you.
No, but you see, immunization has schedule. That question on how long it lasts is not appropriate. Let me tell you why. Immunization has schedule. For instance, 0 dose means taking it at birth. The child is 0 years old, or 0, that's why it's called 0 dose at birth. When you take the first dose at birth before the child is discharged, then the second dose is taken 6 weeks later. Okay, 6 weeks later. See, the second dose, the third dose, the first dose is a primer. When you give the first dose, antibodies form. The first group of antibodies that form, they are the IgM, they are called IgM, immunoglobulin M. Okay, the first, yes. Then by the time you give the second dose, it increases, and you give the last dose, it will get to maximum, and it will now be, when it now gets to maximum, it will now be for life. It will not be for life. The person is not immunized, Do you understand?
Yes, sir.
Yes.
Oh, thank you so
If the
much.
person just has only 1 dose and did not complete, then that 1 dose is not fully primed. It could fizzle out after a few years, and that person will become at risk again. So that's why it is like that. Okay. Next person is that is that okay, go on. Is that Dr. Chioma?
No, Jane Abba.
Okay, Jane Abba, go on.
Yes, sir. And please, my question is still on malaria.
Okay.
I want to use myself as an example. I didn't suffer malaria. The last I knew that I had malaria drug was 2014. That's up until,
You're lucky.
Up until last year, 2024 rather, February of 2024. So it's been like a decade before I suffered malaria. And I even feel that the reason I had it was because I was pregnant in 2023 and I took Fancida 3 times within the pregnancy. So I don't know. I felt perhaps because I had to take some drugs and then it triggered it. I don't know.
No.
But I don't know why. For almost a decade, if not more. I'm
What is your
trying to
genotype? What is your genotype?
AS, sir.
Now he explains it. AS suffer less. If you remember when I called that counselor, I told him, "Are you AA?" He said, "Yeah." I said, "Yeah, yeah." Genotype also explains it.
Okay.
Yes, AS hardly suffer malaria. They are lucky people. They are lucky with malaria, but on the other side too. But AS is completely normal, just as I mentioned to the other person who asked the question. A sickle cell trait means nothing. Means nothing. It's only when a sickle cell trait meets another sickle cell, the offspring is the person who is now at risk, not the sickle cell trait. So it's the AS. There are theories about it, but let's not go there. Our time, I beg. Samson Esther. Unmute yourself and ask your question if you have any. Eze Mesomachi.
Good evening, Prof.
Good evening. Go on.
Prof, can you hear me?
Go ahead. Go ahead. We can hear you.
Okay, so my question is TB. So you can hear me. I'm asking multi-drug resistant TB, and then how do we manage it? That's from yesterday. Yeah.
Okay, multi-drug resistant TB.
Yes, sir.
There are special cases. In fact, yesterday, if you were here, I insisted that it should on no account be managed in a private facility.
Yes,
because
I heard that.
Designated centers and people are properly trained to manage it. Properly trained, because it's a very dangerous form of TB. Now, like in our hospital, we manage it. We have our center. One of our consultants is in charge, and we have the drugs. They are nationally, it's managed under the national program. And the drugs are very toxic drugs. In fact, though there is a modification, now the course is 8 months of treatment. 8 months of treatment now. When it started in many years back, around 2014, when the center started, at that time the treatment was 18 months. Our first group of patients were there for 18 months. And before we start, of course, they must go some first psychiatric evaluation. They will go ENT evaluation, because some of the drug can cause deafness. It's a very the liver, the kidney and liver function tests must be appropriate, because the drugs are highly toxic themselves. So we on no account, the drugs are there, and because they are programmed drugs. Most times you can't even see it on they are not drugs you see elsewhere, because they are just imported directly for the programs. The combinations, yes. So
Prof, as a follow-up,
I don't even. Yes.
Hello, Prof.
I can hear you very clearly.
Okay, I said, as a follow-up, if we have a case of a patient that was treated for TB and then completed the course and got well, a patient that was treated for TB and then got well and then came back after some months, can we classify that patient as a multi-drug resistant
what are my advice in such,
Actually,
okay, the person got cured, right? Hello?
Yeah. Yes,
Okay.
sir.
Then when the person got back,
Yeah. We were
how
not
did
asked
you
to manage
know
as multi-drug
that
resistant.
no? So you just go and manage as
And
multi-drug resistant.
that was exactly
You should
what
have
I
tested.
heard. So I just wanted to confirm.
I know. You should have tested for the drug resistant to know. It could be a single drug resistant. You could have tested for the drug resistant to know. But again, did you repeat a gene expert, or how did you know that there was a resurgence? The network is. Sorry, the network is not helping us now. But my advice in this case, if you're in Port Harcourt, I will advise you to
Our
send the
chief
patient
just
to
said we
us.
should continue.
Please.
It's about network. Okay. Okay, sir. Okay, sir. Okay.
With
Hello,
which
good
drugs?
All right,
evening,
thank you,
Prof.
sir.
Okay. Good evening, Prof.
Hold on now. One after the other, I beg. One after
Okay,
the
sir.
other. I'm answering you, I beg. I will answer you. It's good to use the appropriate drugs for it. If not, you might lose that patient too. So in that case, for me, I will advise strongly that you send the patient to us if you're in Port Harcourt. But if you're not in Port Harcourt, you can look at another center you can send the patient. We have a very big center. Refer the patient to us. Refer the person to community medicine department so that we will take the person to our center. Our consultants are managing it. They are well trained to handle MDR cases. I don't know if you heard me. The network it started misbehaving. It was good throughout.
Sir, can I now, sir?
Anybody can unmute.
Okay, good evening, sir. Thank you for the class.
Please, I'm not muting. I'm not muted. Everybody's on mute. You can unmute yourself if you want to talk. Yes.
Okay, sir. Sir, please, it's about yesterday about vaccination. Please, I want to ask first, can there still be carriers that can still infect others? That is after getting the vaccine.
Can there be carriers that can affect others?
Yes, like after getting the vaccine, can someone still get the disease? I mean, but it will not affect you, but you can give it to somebody else.
Which disease in particular?
Hepatitis B.
Like hepatitis B?
Yes.
Yes. Of course.
Okay.
If the person is a carrier,
okay,
a carrier state can infect people. That is why we are very mindful of carrier states. They are very dangerous.
Okay.
Even after dangerous in the sense that the person, yes. No, if people have hepatitis B, we don't vaccinate them.
Okay. That means after getting the vaccine, you can never get it again. Like it cannot be in your system at all. Okay.
Of course, now that is why you took the vaccine. The vaccine is a preventive measure for the future. If you took the doses complete, in the future, if the person contract it, it will not affect the person.
Okay, and the person cannot transmit it even though the person comes in contact.
No, you can't give what you don't have.
Okay, sir.
If you don't get it, you can't give it. So the person is free. The person cannot give. Yes, that's what it is.
Thank you, sir.
All right. Ebele Chukwu Chinwe. Anybody can mute him or himself. Good evening.
Good evening, Prof. Okay, so please, I also want to ask a follow-up question for vaccination. So for a disease like yellow fever, we all know that when one is vaccinated, it's supposed to give you lifelong immunity. But sometimes you see people who have been vaccinated still come down with the disease. What could be responsible for this?
Sorry, you say sometimes people, is it with particular yellow fever?
Yes, yes. You see people who have received the vaccine, they will still come down with the yellow fever disease.
Wow, it's rare, but it is not impossible. It's not impossible. It is rare, just as I said. But you have yellow fever, we give yellow fever at 9 months. There are some places now they have introduced, just like measles, we give yellow fever and measles at 9 months. And if you observe, you see that second dose measles have been reintroduced. I think that at 15 months now or so. Second dose measles. I don't know that of yellow fever. What happens is that it is possible that some of the vaccines, the immunity wane with time, right? But it's not in all cases. It's not in all cases. I have not noticed that with yellow fever, but globally it was noticed with measles. So measles, a second dose has been reintroduced, second dose measles, at month 15, I think 15 months. But it is possible. One thing you must know about vaccines, there are different types of vaccine. The best vaccines are live vaccines. The best and the most efficacious vaccines are the live vaccines. The weakest ones are the toxoids or killed vaccines, right? Their immune this thing is not as strong as live vaccines. And that is why, like some diseases, people win. Like, take for instance, TB. TB, it does not mean that after the vaccine that the person might not have TB. But most cases, more than 99%, the person will not, right? But peradventure, that 1% is possible that the person will still have TB, haven't been vaccinated. But what will happen in that case is that the TB vaccine protects against severe tuberculosis, the one called miliary TB or tuberculous meningitis or meningoencephalitis, but mainly meningitis, tuberculous meningitis. These are severe forms of tuberculosis that are very fatal. They almost kill the patients. So, but somebody who is vaccinated will hardly come down with those severe forms. So it protects against severe form of, tuberculosis, just as it protects for the ordinary TB, So it is possible to have, after vaccination. But however, the assurance is this: for any person who is vaccinated and comes down with that disease, is usually mild. Quote me anywhere. It's usually mild. It will never be the type that the person can succumb to. It will never be the type. All right, Danjuma. Yes, Danjuma. Yes. Then Job Mary, then we'll end up. Yeah, good evening. Go ahead.
Sir, good evening. Is Dr. Choma. Good evening.
All right,
sir.
go ahead.
Thank you so much for the lecture. Please, I want to understand something.
Yes,
people that don't fall sick, that don't have malaria, does it mean that they are okay? Because I want to use myself as an example. Over the years, like I can't remember which year, I've never fallen sick before, not to talk of having malaria. And the same with my kids. I want to know, is there a problem somewhere, or are we supposed to just want to go and take malaria medicine, or I don't know.
Don't take malaria medicine. You will cause resistance for us. If you are not sick, you don't have reason to take malaria medicine. If you are not sick, particularly of malaria, probably because you are AS, your genotype. Or
my genotype is O positive.
Blood group.
I mean, your blood group. Sorry.
Is O positive.
No, if see, your blood group is O positive. I mean, they are genotype. They are, you know.
My genotype is A. Is
AA.
A. Yeah.
The
Yes,
another thing another factor that can maybe if you check your environment, it's not malaria infested environment. Maybe where you stay. Neighborhoods differ. And depending again on the neighborhood, you know, there are some neighborhood you are more or less free. And if maybe, yes, or if maybe you are using bed nets and all that, then it's working. That's just what it is.
So, but we don't use bed nets. Like where I was in Edo State before, we don't still suffer malaria. So why I came to Port Harcourt to have not still experienced it. So I was trying to know if something is wrong somewhere, or we should once take malaria medicine in case. Even yes, but the doctor said it's not advisable when you are not sick for you to go and take malaria medicine. But I just want to know if those people are really normal.
It's not. They are normal. You know, it's normal. You are not sick. It's not advisable actually to take drugs when you are not sick. You can take preventive measures, environment, but not with drugs. The only time we use drugs is maybe like in pregnancy, or like where we do seasonal malaria chemoprevention for children under 2 years. In some areas, that's where we use drugs. But generally, why we don't, that is why I told you, like, the country, we don't approve, Nigeria does not approve mass drug administration, MDA, for malaria, because when you do such things, you can push the society into drug resistance. So that's why we don't do that. That's why it's not do that.
Good evening, Prof.
Yeah, good evening.
So thank you, sir.
Thank you.
Good evening, sir.
It's Wally, serious. Hello, sir.
Go ahead.
Sir, I want to verify the mechanism behind the serodiscordant couple, as in HIV. Then the second one has to do with the between the check secretary and the gene expert. Which one has more advantage in the diagnosis of TB? Yes. Then lastly, it has to do with the lung cancer and the prostate cancer in men. Which one has high mortality rate, and which one is common as in cancer? Whether between prostate and lung cancer, which one is common, and which one is common with respect to mortality?
All right. Let's start the first question about serodiscordant couples. Serodiscordant couples are just, that is, one couple is HIV positive, the other couple is HIV negative, right?
Yes, sir.
And how would it have occurred? It is possible. It is possible. There are, again, it depends on if you are tested them for how long. If maybe one couple, if it is discovered early, and the couple are now using preventive measures, then you can have, you know, if both of them were seronegative, it is one person that brought it in. It is one person that brought it in, right? And if the person that brought it in, if it was discovered early, preventive measure will be taken and prevent the other person. That is one. Two, you also have to be very sure that they're actually serodiscordant, because HIV has a window period that can be anything from 3 months to even 1 year. Okay, and not manifested. Normally we see up to 3 months to 6 months, but you know what determines
Sir, this family has a history of a previous two children. The elderly one is 4 years, is positive. The second one is 2 years, is positive. Then plus the index pregnancy. But the man is negative.
Which level are you now?
And the man is negative, the woman is positive now.
Yes.
And do you know whether they are it depends.
The first child is 4 years and is positive.
There are counseling that they undergo that enables them to know how to get pregnant. Yes, enables to know how the woman can get pregnant without him. Yeah. There are safety measures that are applied. Okay. Yes. It is possible. But the unfortunate thing is that why they should allow the children to be positive.
Yeah.
When is either the woman is not on treatment, she's not virally suppressed. She's not virally suppressed.
No problem later.
If she was virally suppressed, then the chances of the man remaining negative are high. So their case needs to actually look into. Their case needs to look into.
Good evening, Prof.
Somebody say they use alkaline water. Okay, yeah, you can use alkaline, but the chances are there. But the case need to look into actually. I don't think it's strong immune system, or I don't think there is no amount of immune system that will stand HIV. Or there is no it's not immune system. It's not immune system. I don't think so.
Good evening, Prof.
With concerning the question on the TB.
Yes. Okay. The TB, the either gene expert or X-ray.
Yes, sir.
Yes, you see, X-ray is what you can see. Gene expert is molecular. Can you hear me?
Okay.
If any person is not asking questions, just unmute yourself so that we can.
Yes, I
just
have
mute yourself. So gene expert is molecular. So X-ray is what you can see. So the molecular is more sensitive.
Okay.
But though it's a rapid, but the gold standard when it comes to TB is bacteriology, culture. But we don't use it very often because it takes time. It takes about 6 weeks, So gene expert is, for me, more perfect because X-ray can be misinterpreted. But the gene expert will be more objective. X-ray is subjective, is the feeling of and the training of the radiologist. You can get it wrong if it's not, an expert. But gene expert will be more because it's what you can get from the molecular, from the blood. Okay.
Prof, good evening, sir.
Good evening.
Okay, mine is on vaccinations.
Okay.
And hepatitis B vaccine, what's the appropriate dose for an adult? Some people say the dosage duration. Some people will say you take the 3 doses within 3 months, and some will say it's 6 months. So which one is the right one for an adult? Thank you.
For which one?
Hepatitis B.
Okay, schedules change. Initially, the very first this thing was initially when it came, it was the national program first is 3 months. So after first week, 6 weeks, a month. Is 6 weeks, 4 weeks, 4 weeks. What is that? Put them together. How many weeks? Okay, wait. 0, 6 weeks, 4 weeks. Is within, okay, if it is children, it's within 3 months. For adults, I don't know. Adults, I think it's within 3 months. So it's 1 month.
Prof, it's 3 months.
It's 3 months. 3 months. It's
Yes,
not
sir.
6 months.
What
It's
about
3 months.
human papillomavirus? Human papillomavirus, are they still the same 3 months, or that one differs?
Human HPV. HPV is, I think is, I don't know, I can't remember exactly the last time I checked. HPV. I think it's 3 months too. HPV, 3 doses is 3 months. 3 months. 3 months. It's not 6 months. 3 months.
Okay, sir. Prof, good evening,
Yes.
sir.
Good evening.
Yeah, very close to this one. Like in my own case, I took the hepatitis B vaccine, I think sometimes around 10 years back now. So recently I met with a colleague, and he was trying to, I don't know, is it stigmatize me or whatsoever. So he said after 10 years, the efficacy of the drug tends to elapse. So he was trying to create fear that after 10 years, you need to still be vaccinated for hepatitis B. So I just needed to be sure, how true is that information, Prof?
We don't have such. I don't think it's true. I don't think it's true. We don't, you see, all these doses and schedules are based on epidemiological evidence. If it is like that, then the country will change our, as I said earlier on, vaccine schedules change. They change with time. Many countries have different schedules. So you might find out that the schedule Britain uses might different from the schedule Nigeria uses. Why? It is based on epidemiological evidence, what happens in your own local environment. That is what it is based on. So at times, if a particular schedule is not working well, we can do a study and change that schedule. So if what is saying that after 10 years that it wanes, you need to do that, then I don't think so. I don't think, let him, at the level we are now, any person give you such this thing, can you ask him for evidence? Are there studies that say so? Yes, because we are developing science at our level, we should know what is the evidence, what studies say so,
Okay.
Yes, where is it getting it from? This thing shouldn't be by hearsay. And this person say this one. No, it's something that goes into your body, can be, So let me show you evidence.
Sorry, Prof, a doctor said after 10 years, the person should take a booster dose, just a shot.
Okay, booster dose.
Yes.
Okay. Okay, a booster.
Okay.
Okay, it's not that the person should go and revaccinate.
No, not revaccinating, just a shot, a booster dose.
Okay, booster dose, maybe to pop, like a top-up booster. But even at that booster dose, it's not in our schedule if you watch. But these people who are saying this are clinicians, maybe based from evidence from practice. you know, from their observation, from practice. So these are possible. But I don't think we have adopted it as a policy. I'm not aware, actually. Okay, or maybe they have adopted it. I'm not aware, really. I won't.
So maybe I will make more inquiry about it.
Exactly.
If the really matter.
Yes.
Dr. West, I have a question.
Okay, well, we have last question. It's
Okay.
already 8 o'clock. We are supposed to.
Thank you very much. My question is a little just to say that we are very pleased with the way you have engaged us with your lectures so far, and we've been following. I particularly have followed from the beginning. They are very helpful, even if just as in terms of knowledge, but also in terms of applying in our personal lives, in our homes too. It's been very useful.
Yeah.
So now we are looking ahead to write our exams very soon.
Yeah.
Is there a way you can kindly ask, because I'm speaking the mind of a lot of persons. You know, in this group we
Let's
have.
talk about your exam. I think from our schedule, they're supposed to do your exams on the 10th, right?
Yes, sir.
That's next week, Friday. So
yeah.
I think we are going to give you 2 tests. One is we'll use one as a continuous assessment.
Okay.
And that will be a short one. Then the other one is a longer, slightly longer one. Is going to be for an hour and a half. An hour, and that's 90 minutes. 150 questions, MCQ, 90 minutes. 150 questions, MCQ, 90 minutes. Then the short one we are going to use for this will be a shorter one. I'll get it from Professor Maduka. It's a shorter one, not, you know, so that because of your share number, we don't want I don't think we'll have strength for essay. So let's just do MCQ. But never mind, whatever the questions are usually very simple, straight to the point. But I think we are very user-friendly, so I don't think students have to be very worried about it.
So the exam has been postponed.
Yes, it has been
on the 10th.
Yes, and 15th.
Okay. They did not inform me. I'm not aware. I was looking at what was the timetable.
Yeah, it's 15th now.
Today.
Okay, it's today. Is it postponed to when?
15th.
15th.
Okay, from 10th to 15th.
Yes, sir.
Okay, no problem. You will still do it.
Interval.
No problem. But from in between, you still be doing another course will come in.
But epidemiology is on 17th. It's ethics that is on 15th.
Yeah.
Okay, in that case, maybe we will give you a continuous assessment now. You do that one. I'll ask Maduka to give you, that is another short episode.
I've done Dr. Maduka done an assessment from Professor Maduka.
Okay, you have done it.
But not everybody. Not everybody has participated in that.
No, that one, that's not an excuse. You have done it, you have done it. There's no way she yeah, if you did not, if you miss it, I'm really sorry for you. You missed 30 marks already. Don't tell us not everybody. You have missed 30 marks. Sorry.
It's like the time given was too short. Many people are not online that time. Many people have not done it.
The story has changed. See, we can't give exam. We are your teachers. You cannot dictate to us when to give you exam, not to. Please. This is a school. Even though we treat you as adults, but you can't choose, you know. When I didn't know that she has given to you, normally we give you continuous assessment and you will do it because it's part of it. No matter the little you score, there is a score. But when you ignore it, and we cannot, you know, exam, you can't give it away. The day you choose, you do it. You know, we don't do like that. If you miss it, you have missed it. So the exam will be on the 17th. Whatever date, we will do it that day. Whatever the date, no problem with that.
Thank you, sir.
All right,
Thank you.
so
Bye-bye.
see you.
Prof, thank you very much. Please, good night. Prof, please go and rest. Thank you, sir.
Prof. Thank you.
Prof, please go and rest.
See you. Good night.
Thank you,
Thank
sir.
you,
Thank
sir.
you, Prof.
Good night,
Good
Prof.
night.
Thank you.
You've really
God
tried.
bless you.
God bless
Thank you,
you.
Prof.